in the coming 20 minutes or so, I'm going to share with you some updates about HS management. This is the agenda. I'm going to discuss some of the important points about the HS, its definition, its burden, its pathophysiology, different lines of treatment and management, surgical approaches, and I'm going to share with you some of the new data about the use of IL-17 inhibitor, secukinumab, in the treatment of hidradenitis suppurativa, and to share with you some of the data about the use of this molecule. All of us knows that hidradenitis suppurativa is a chronic recurrent inflammatory follicular skin disease, and usually it is progressive in a good majority of the cases, and it is characterized by the delayed diagnosis. There are several years, up to 10 years, delayed in the diagnosis from the first visit of the patient to the any healthcare provider, and it is about 7 to 10 years has been reported between the onset of the symptoms and the HS diagnosis, and in spite of the frequent visits to the physician repeatedly every time the patient developed some of inflamed nodule or an abscess or whatever, he visit the healthcare provider without receiving any diagnosis. Of course, as a chronic progressive disabling disease, it has a significant impact on the quality of life, which has been measured in many studies, and it has severe impact on all the domains of quality of life. Working disability, impairment of sexual health, depression, social ideation, stigmatization, name it, whatever the effect on the quality of life, it is usually associated with cases of hidradenitis suppurativa. Again, just to remind ourselves about how it appears, it is usually a chronic recurrent inflammatory follicular disease characterized by the appearance of inflammatory nodules, abscesses, fistulas, sinus tracts, hypertrophic scars, and usually it affects the area which is typically located in the apocrine gland-bearing area, and that's why in the very old people like myself, when we start learning dermatology, we thought that it is a disease of the apocrine glands, which proved not to be the cause. It is the inflammation or it is the pilosebaceous unit disease. But because it is commonly affecting the apocrine-bearing skin, like the axillae, groin, and in women in the inframammary area and intermammary area, and it is 3 more times affecting females more than males. Of course, the diagnosis of, we as dermatologists, we can easily diagnose hidradenitis suppurativa, although it is not the case with other specialties, and most of these cases goes or went first to other specialties like the surgeon, the GP, the accent unit, the gynecologist, whatever. But make it short and brief that the primary criteria for the diagnosis, of course, the history of recurrent painful papules, nodules, and inflammatory lesions and abscesses in these specific areas, in addition to are very characteristic, and this is a primary criteria. Family history of the same condition, again, can help in the diagnosis as secondary criteria for the diagnosis. And usually, and this is, we see it in many cases, that those patients undergone bacteriological swabs and culture, and most of these are either sterile or does only have bacterial commensals on the skin, and repeated courses of antibiotics, either empirically or whatever has been advised by these patients, has been advised to these patients. Again, there are some additional diagnosis which rarely we can go to do it in addition in an attempt to diagnose the cases, like biopsy. I don't think that very rarely we can need a biopsy, but imaging is really important, not in diagnosis. It is really important to diagnose the severity of the condition. Are those patients have just early stage of recurrent inflammatory nodules and abscess, or there is an under the skin tunnels and sinus tracts? Because here the treatment will be completely different. Sometimes you can read here or there that there are some markers, but usually markers are not helpful in diagnosis. But We know that many cytokines have increased level in the skin and the serum of those patients, like the TNF-alpha and like the IL-17. And this is the rationale behind of using these two molecules in the treatment of moderate to severe cases of hidradenitis. These are some examples of clinical pictures of some cases of hidradenitis. On the left-hand side, it is the painful inflammatory nodules, and when it is more progressive, forming an abscess, one abscess or multiple abscesses even. And this is an advanced case with nodules, abscesses, and even sinus tracts, fistulas, and hypertrophic scars. And this is really an advanced case. So the disease course is usually persistent, recurrent, and chronic. Whatever the definition of each one of these, but we know it is persistent, it is recurrent, and the patient have more than 2 or 3 flares during a very short period of few months. And sometimes the lesions are persistent all through life with flares. The patient ends in continuous flares. Again, this is one of the challenging topics about hidradenitis suppurativa, how we assess the severity of the condition. In addition, and we usually assess the severity to have a proper treatment, like in any chronic inflammatory condition, like atopic dermatitis, like psoriasis, like whatever, we have to have some tools to assess the severity. There are many tools to assess the severity of the hidradenitis suppurativa, but most of them are not used except in the setting of clinical trials. But the most commonly used are actually not the 3 of them, the early staging system and the IHS4, which is the International Hidradenitis Suppurativa Severity Score System. I'm going just to share it with you in 2 minutes. But the high score, which is hidradenitis suppurativa clinical response, is usually used to assess the efficacy of any treatment regimen in cases of hidradenitis. So early staging and IHS4 to assess the severity, while the high score to assess the effect of any treatment. Again, quality of life is very important to be assessed during the treatment of those patients, and to see the effect of any molecule we are going to use it in the treatment of HS. Don't forget that almost 97 to 98% of those patients are suffering of severe pain, severe continuous pain most days of the year. If you ask any one of your colleagues who is working in the States, they are using a lot of opioids to control the pain of such patients. So most of us, including myself, we forgot this part in the management of patients, but believe me, it is a very important part. This is the early stage, and the early staging, which is a surgical one rather than a clinical one, but it is the most commonly used. It is the most commonly validated one, although it has some limitations. And we usually classify the patient stage 1, stage 2, and stage 3 according to the prevalence of the inflammatory. Stage 1, it is like in the first picture, it is only single or multiple abscesses without any sinus tracts, without any cicatrization. If the disease progresses and becomes more recurrent abscesses with tracts, even single tract or multiple tracts, it does indicate that cicatrization started and the patient has been moved to stage 2. And stage 3, which is the last one, it is diffuse or near diffuse involvement or multiple interconnected tracts and abscesses across the entire area, and usually associated with hypertrophic or even atrophic scars. It is very commonly used, it is validated, but fast and easy to use, but it is static. It is static and I can't use it in monitoring my patients, and the most important, it does not consider the quality of life of patients. The second one, which I mentioned, is the total IHS4 score, and usually it is used in clinical studies rather than in clinical work, although it is more descriptive than early staging. But it does measure the the major clinical signs of the condition: the number of the nodules, M, number of abscesses, A, and the number of draining tunnels, T. And each one of these has a relative weight. If the patient has 4 nodules, because I'm going to multiply by this relative weight, 4 nodules, it means the N is 4, because I multiply by 1. But if it has 2 abscesses, it means the A score will be 2 by 2 is 4. And the number of draining tunnels, each tunnel multiplied by 4. And then we are going to summate, so the total IHS4 score is the sum of N, A, and T. And the grading, 3 or less, it is mild, and 4 to 10, it is moderate, and up more than 11, it is severe. Again, it does not measure the quality of life, and it is intended usually for physicians who are working in more academic work, but it can be used as well in everyday clinical science. But it does not used in cases of monitoring the patients. This is the one we are going to the high score, which usually this is the most commonly used for assessing the efficacy of any line of treatment in cases of hidradenitis suppurativa. And the benchmark is what we call high score 50. By high score 50, like easy 50, like PASI 50, high score 50, it means 50% or more reduction in the number of inflammatory lesions, which is the abscess and inflammatory nodules, but there is no increase in the number of draining sinus or fistulas. So if those patients have marked reduction in inflammatory lesions while they develop during treatment, even 1 tunnel, the high score 50 is not achieved. Again, it is a meaningful endpoint for many of the studies, but it does only include clinical signs of HS and does not assess the quality of life of patients. Again, this is the very well-known quality DLQI, which is the most commonly used, although there is a specific one for HS, but this is the most commonly used among cases of HS as well, because it does measure many of the domains of quality of life of patients. So usually we used one of the to assess the severity, either the early stage or HS4, and the high score, and the DLQI to assess again the impact on the patient's quality of life. So most clinical scores are not detailed enough to precise descriptions of disease severity or for the therapy outcomes. And sometimes even the scores, especially in the very advanced cases like early stage early stage 3, when most of the lesions are intermingled with each other and no specific nodule you can identify as solitary nodules, although the scarring and the induction and the infiltration is very massive. So, and most of this does not measure the quality of life. So still, although we have many tools for assessment, still none of them is enough or actually precisely describe the case of the patient. But again, the triggers factors, I'm just I want to attract your attention. The etiology of the disease is multifactorial, including the immune dysregulations, genetics, endocrine factors, but it goes beyond doubt that smoking and obesity are very highly prevalent among patients with HS and are considered as an independent risk factors. And it has been proved in many, many studies that smoking and obesity are almost 8 to 10 times more prevalent among patients with HS when compared to the general population. So you will find very important points in the management of cases, cessation of smoking and weight reduction, which help a lot in the treatment of cases. Again, I'm not going to go so details in treatment of hidradenitis, but we know according to the disease severity, we usually start with the topical treatments, not only clindamycin, and with the condition becomes more and more severe, we have to use both medical treatment in addition to surgical interference. There are many systemic medical treatments. I'm not going to go deeply, but there are many, like oral antibiotics, like hormonal therapy, like acitretin, isotretinoin, and even some of the new biologics are used. In addition, many surgical approaches according to the most prevalent clinical picture of the patient. These adjuvant therapy are very important as well, as I mentioned before. The pain management is really very important. The weight loss and tobacco cessation is important. Super infection, this is and if there is super infection. This again another landscape for the treatment. I'm not going, just I show this to share with you that there are many biological treatment can be used, but biological treatment alone is not enough. Those patients who are going to receive the biological treatment, they are the patient with moderate severe HS. They need both surgery and medical treatment at the same time. It is a responsibility of both the surgeon as well as the dermatologist. So the biological treatment which has been used in cases of HS, adalimumab, infliximab, ustekinumab, etanercept, secukinumab, and anakinra. Anti-IL-1, anti-TNF alpha antagonist, as well as IL-17. But the approved are only two, the adalimumab and the secukinumab. The secukinumab has been recently approved by EMA in May 23, and in the United Arab Emirates in June 23, and by FDA in October 23. Adalimumab has been approved several years back, but the others has not been approved, although it has been used several times as an off-label indication. Again, there are many surgical approaches for those patients. The surgeons know it much better than me. Not all surgeons are interested for cases of HS, but it is from very simple maneuvers up to complete skin thickness removal and grafting and flap closure. Those patients are usually have a very long healing time, very long post-surgical care, and that's why many of the surgeons do not like to be indulged with. It has very high recurrence rate if it is not associated with a continuous anti-inflammatory medical treatment. The inpatient stay after the operation extends for weeks and months, because many of these, especially in the full thickness removal and grafting, secondary intention is the way how those patients are healed, associated severe pain, and of course the financial burden. So we have, as healthcare providers, we have a small window of opportunity to help those patients not to progress to these severe conditions, and they need a continuous treatment and a massive surgical interference. What I mean, early diagnosis, early intervention. Early diagnosis, which is not the case, I'm sorry to say that, in clinical and everyday life, there are many delays in the diagnosis of the patient, but early intervention will keep the patient in the lesions which are inflammatory and non-inflammatory induced, minimal abscesses which are reversible by some treatments. But delayed treatment lead to all the irreversible lesions like tunnels, fistulas, scars, which are really very troublesome to the patients and usually associated with frequent flares. So our opportunity remains in this small window with early recognition, early treatment. The Sunshine and the Sunrise clinical trials, these are the two identical clinical trials, pivotal studies, which has been done with secukinumab for the treatment of cases of moderate to severe HS, and they are so identical. These are two randomized, double-blind, multi-center studies to assess both the short and the long-term efficacy and safety of the disease. The short term, the primary endpoint was 16 weeks, but most of the patients has been followed up to 1 year to assess the long-term efficacy and safety as well. There are two studies which enrolled more than 1,000 patients, almost 1,100 patients in more than 200 sites all over the world. And it's very simple. It has 3 arms. 2 arms for secukinumab. The first arm, 300 milligram every 2 weeks. The second one, 300 milligram every 4 weeks, to be compared with the placebo until week 16. After week 16, even the placebo patients has been re-randomized to receive either the 300 milligram every 2 weeks or every 4 weeks. So at 16 weeks, the primary endpoint of the treatment period 1, and this, I'll tell you what's the primary endpoint. It is usually the highest score, 50. But after 16 weeks, even those patients in the placebo group has been re-randomized 1-to-1 First group received the every 2 weeks dose, and the other group received the every 4 weeks group until the end of the first year of treatment. Here I have to mention a very important fact that almost 1/4 of these patients which had been enrolled to receive the secukinumab, they tried adalimumab and they proved to be inadequately responding. So good number of those patients received adalimumab before, but the response was not that good. The primary endpoint at week 16, it is to demonstrate the efficacy of secukinumab compared to placebo with respect of high score 50 at week 16. But there are many other secondary endpoints about the inflammatory or abscess and nodules count, the number of flares, and the HS-related skin pain, which every time I'm going to stress this, and it has been measured by a numerical rating scale of visual analog 0 to 10, where 0 is the least pain and 10 is the highest pain. And in order to achieve this secondary endpoint, the patient should achieve at least 30% reduction of the severity before treatment with at least 2-point improvement of this analog scale. There are many other exploratory endpoints, but I'm not going to go deeply into this because the effect on the quality of life, the effect on the productivity, the effect on the absenteeism, and the long-term effect, again, I'm going to discuss with you in a very short time, not only high score 50. This is just to show the high score 50. In both groups, those who are using the 20 milligram, the every 2 weeks or even the 4 weeks, we can see that at week 16, almost 45% of the patients were able to achieve high score 50. And with the continuation of the treatment, whatever it is, 2 weeks, even after 16 weeks, with the 4 weeks regimen, almost 60% of the patients were able to achieve high score 50. So with the continuation of the treatment, again, more and more patients are going to improve. And you can see at the end of the first year, almost 60% of the patients were able to achieve this treatment outcome. There was a marked decrease of 50% or more in the baseline abscess and nodule count without any increase. This is the definition of high score. Again, the relief was really very fast in the, it can be, many patients show marked relief very early in the treatment, even after 4 weeks of the treatment. But with the continuation of the treatment, you can see that even almost 70% of the patients of the first year were able to show decreased number of abscesses and inflammatory nodules. Of course, all this improvement of the first year has a very good impact on the patient's quality of life. And we can see that even 71% reduction on the number of lesions after first year of treatment, 70% the pain reduction, 73% flares free, which is very important. More than 80% had no increase in draining tunnels. Otherwise, they are not going to achieve high score 50. And 50% improvement in the quality of life measurements, the DLQI. So there are marked improvement in both physical symptom signs and impact on the patient's quality of life. Just this one I'm going to share with you because it's very recent. And even it was, for me, it was really very recent. Not only the high score 50, the high score 70, the high score 75, high score 90, and high score 100, like exactly in PASI. So, just I want to explain a little bit here. Sorry, this is the sunshine. This is the sunshine, and this is the sunrise. Those are the patients who were receiving every 2 weeks after the first year, and this is the patients who were receiving every 4 weeks. And you can see almost 40% of them were able to achieve high score 75 at week 52. Even the patients who are shaded like this, those are the patients which were in the placebo group and has been shifted to receive the active arm. Even more than 1/3 of those patients were able to achieve high score 75. Again, if we go to the high score 90, the high score 90, we can see again at week 52 that almost 30%, 25% of the patients who are receiving the secukinumab were able to achieve high score 90% reduction in the number of the abscess and nodules without development of new tunnels. It's almost clear. And almost, in the other one, the 100, almost 17 to 18%, almost 20%, 1 out of 5 patients have complete healing of all the lesions without any flares. I think these data for me are really very impressive, that at least 40% of the patients were able to achieve high score 75, which is really my first time to see any medicine can show high score 75. I'm sorry. Okay, just a minute. So I'm almost to finish. It is the same one, but in another graph. So I finished. Thank you. It was the last one.